Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essential Season 3 with Dr. Sanjay Kalra. Doctors, as June to October are high OPD tropical fever months, that we have bought special six lecture series on tropical fevers. Today is the fifth lecture on tropical fevers. You can access all the previous four lectures on our archive. And today's topic is tropical fever with systemic involvement. Diabetes Essential is brought to you by your zero calorie electrolyte drink Innozal Zero. Now, before moving forward to the topic, I would like to announce the last week quiz winners. Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Gangadhar Rath from Bhubaneswar, Dr. Kaval Saluja from Mumbai, Dr. Atul Doshi from Mumbai, Dr. Surjit Kalsi from Noida, Dr. Farid Khimani from Mumbai, Dr. Javed Ahmed from Lucknow, Dr. Shashi Khare from Bhopal, Dr. Ramesh Hegde from Bangalore, Dr. Pradeep Patro from Chhatarpur, Dr. Suhas Pese from Kankavali, Dr. Pradeep Pahtade from Vashi, Dr. Satish Kumar Jain from Bangalore, Dr. Ashwani Kumar from Kanpur, Dr. Pramod Umarji from Pune, Dr. Sanjeev Puri from Hoshiarpur, Dr. MP Gupta from Araria, Dr. Ravi Bhatt from Sirsi, Dr. Sanjay Shiroha from Surat, Dr. Sumit Sharma from New Delhi, and Dr. Rajiv Handa from Delhi. So thank you all the doctors for taking part in our quiz. Now, before moving forward, I would like to announce. Uh, I like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. It's great being part of Diabetes Essentials. And sometimes when I have to miss being in this show because of personal reasons, I don't feel good, and I miss you all a lot. I must say that. But we are back now, and today we have a guest, an expert, who is going to speak to us about difficult aspect of managing tropical fever. But when the going gets tough, the tough people get going. So today we have a very tough, very seasoned kind of warrior, somebody who's going to talk to us about difficult to manage tropical fevers. And this is Dr. Sandeep Suri. Warm welcome to Dr. Suri.
Hello. Hello. Good evening, friends. Good evening.
Thank you. Dr. Suri and I go back a long way. We did our MD together. So we did
Yes.
all the good things and all the naughty things together.
Yes.
And today he's an expert in internal medicine and diabetes. He'll be talking to us about tropical fevers, and this is an ongoing part of our series. So, Dr. Suri, before we begin, how is your OPD and how is your indoor these days? How many patients come in with a chief complaint of fever?
Yeah, I think if you take around 100 patients a day, and 40, 50 cases are of with fever, and half of them are being basically having fever and various complaints, and they require, and out of half of them, half require admission also. So you can just my ICU, that is 12 bedded ICU, it is nearly 70% filled by the patients having fever with all complications. So we have got malaria also, but not much. Dengue, most importantly, dengue is there with dengue shock, dengue hemorrhagic fever. We have got recently scrub typhus also suspected case with the lung involvement, and we have also patient with swine flu having lung involvement. Patient is on ventilator also and requiring, or two patients are on non-invasive ventilation. I think they are all sick people which are with their with being 70% are filled with ICU beds are filled with these type of patients.
So, would you like to share some tips and tricks with us, some hacks and heuristics? How can we identify these difficult cases and how can we manage them?
Yes, first and most important thing is that awareness. Definitely, we are aware about dengue, we are aware about typhoid, we are aware about the malaria. But scrub typhus, leptospirosis, they are also common now. They are also common. If you see, every season I have one patient of scrub typhus, one patient of scrub typhus every season. That means you can have around. If you see my total experience about scrub typhus, around I have seen around 15 cases of scrub typhus, various presentation. These were the patients who were diagnosed, and many of them I think I have missed also. So awareness is very important. Then rapid diagnosis is very important. We have got very important tools now. Immunological diagnosis is there, and but we must know when should we use these type of tests. And then very important, our clinical sense, which we have developed from the years, our knowledge of medicine, our clinical sense, whether patient is stable, patient is deteriorating, vitals, hemodynamics are changing, requirement of ICU, requirement of admission. These are very important signs and symptoms. We must look in each and every patient presently which are coming to us with fever nowadays, because there are so many overlapping symptoms, so many overlapping signs that you will not be able to pinpoint the things right at the beginning. So many patients you have to put indoor and see how they are, how they behave. And there are rapid changing scenario also in these patients. There are certain phases when patient is absolutely okay, but when you look at the reports, there is a lot of thrombocytopenia, there is plasma leakage is there is a lot of capillary fragility, and even in the signs of fluid overload will be there. So you have to watch these patients till they go out from ICU, they go out from HDU, they are better at home, and up to first follow up, you have to follow these patients very importantly.
So the ABCD that you are mentioning, A for awareness, B for blood tests, of course, other tests as well. It might be CSF, it might be urine. But just to remember, B for blood test, done at the right time. The right test done at the right time and don't delay. C would be for common sense, clinical
Yeah,
sense.
definitely. That's very important.
And we look forward to learning from you about that as well. And then D would be for dynamism.
Yeah.
Fever is not static. Let us say you've diagnosed or you think that somebody may have dengue today. The situation can change tomorrow. So be open to changing your diagnosis and also changing your treatment.
Yeah.
With this, Dr. Suri, we look forward to listening to your presentation and
Sure.
lots and lots of questions coming up. We'll take them up
Sure.
at the end.
Sure. Sure. So can we have my slides? Yes. So they are there. So friends, tropical fevers, and I must thank Sanjay for making me a part of this webinar series and pulling me out from that those non-communicable diseases, diabetes and diabetes-related complications, which I think I'm discussing even in the sleep. And he just said that you have to talk about tropical fevers, and I said yes, okay, why not? And we are managing these type of patients routinely. Why not to share and also learn from our colleagues? So tropical fevers with systemic involvements. What are tropical fevers? Basically, these are the fevers which are there in tropical and subtropical areas. And India, as near to the equator, our temperature, hot climate at there that is favorable for tropical fevers, because most of these tropical fevers are having a vector as a mosquito or a tick is there, or it's a mite which is there, and uh, they are all uh, the vectors which can survive this type of temperature variations. So, and most of the time this temperature variation is between 5 degree between the night and daytime, and winters and summers they are just not having much difference in the temperature. Very few months are very chilly and very few months are very hot, but most of the time you can see the temperature remains between 5 to 7 degree difference. So that is the favorable for the favorable temperature for these type of vectors. So these are the tropical fevers which we have: dengue, malaria, scrub typhus, leptospirosis, and typhoid. These are important five uh, uh, tropical fevers which we have, and these are the infections which are prevalent in our or are unique to tropical and subtropical regions. Throughout the year they are occurring, but specifically when you are having post rainy season that we are presently having. A large number of patients require intensive care unit requirement depending upon their hemodynamic profile, their organ dysfunction. They require organ support and mechanical ventilation in the form of mechanical ventilation or renal replacement therapy, may be requiring ionotropes or vasopressor also, may be requiring blood component therapy if they are having multi-organ involvement or multi-organ failure. So most of the time when they present to us, we are not able to diagnose which is a dengue, which is, yes, in the gut feeling is that we can survive on our gut feeling, that we know that this patient is having malaria depending upon the history. This patient is having dengue, but many of them, around 70%, we don't have clear cut diagnosis right at the beginning. And then we know that various tests which we use to diagnose these type of fever, that is particular important time period, phase of the fever, phase of the illness, where these tests will be positive. So maybe immunological tests are routinely positive after 5 days of the fever. If you take typhoid, if you take scrub or lepto, after 1 week of 1 week of the fever, you find these type of tests getting positive. So before that, you have to rely on your clinical sense. So you can have various syndromes. It can be undifferentiated fever, and among that, all these type of tropical fevers can be a form of undifferentiated fever, acute undifferentiated fever. The duration of that will be less than two weeks. Fever with rash or thrombocytopenia. Again, very, very common syndromic presentation of dengue, of scrub typhus, of meningococcal infection, specifically Neisseria, malaria, leptospirosis, measles, rubella, and we do have these type of patients. Our staff also suffered recently with a very fulminant type of measles. Two of our staff, because of one patient which was lying with us and he was having measles. Fever with ARDS is again very common. Two patients are lying with me presently. One is on mechanical ventilation and still coming out. And today we went for tracheostomy after taking care of her coagulation profile. We went for tracheostomy and we are preparing for the long-term fight for this patient. And patient is coming out and organs are preserved and patient is conscious. Again, one patient is having non-invasive ventilation. Patient having fever with ARDS, scrub typhus, falciparum, or influenza H1N1. That lady was having H1N1 infection, and even hantavirus has been reported and having involvement of lungs and also renal involvement. Then community acquired pneumonias also play a big role in during this type of period, and also streptococcal pneumonia. Febrile encephalopathy. One patient, we have Japanese encephalopathy recently, and this patient has encephalitis, had seizures, altered sensorium, and patient improved with seizure therapy and with some amount of decongestive therapy with supportive measures. So, and no antiviral was given in this type of patient because we were able to prove Japanese encephalitis in this patient. So, encephalitis, meningitis. You have to differentiate between encephalitis and meningitis, because in meningitis you will have all meningeal signs, and when you do the CSF, the pressure will be raised. Where in encephalitis you will have altered sensorium, delirium, psychosis type of patient, abnormal movements, or focal deficit, or a seizures that will be there, but CSF pressure will be normal, and you will not be having any meningeal signs. Combined together, we can have meningoencephalitis, and this is very important when you talk about scrub typhus. Cerebromalaria, very important, and then typhoid encephalopathy do exist these days. Fever with multi-organ dysfunction. You can have bacterial sepsis, falciparum malaria, leptospirosis, scrub typhus. All these can lead to multi-organ dysfunction, and even hepatitis A and E, specifically when you sometime in patients with pregnancy, if you talk about hepatitis E, it can lead to fulminant hepatitis and hepatic failure also. And you can have hepatorenal syndrome, hantavirus infection, hemophagocytosis, HLH type of syndrome that can be there, and that can be a terminal event to all these type of infection. They can push the whole of the immune system towards HLH syndrome. So you have to be very, very vigilant these regarding these type of issues. So what is scrub typhus? The causative organism is Orencia tsutsugamuchi. It's a, a it's a rickettsial bacteria, which is rickettsial, and it is gram-negative coccobacilli. It's intercellular obligate bacteria. Vector is chiggers, or it is a larval stage of the that mite, the tick larval stage of mite. So this is because larval stage feeds upon the from the blood of the vector of the animal or the vector. So this is and the pathophysiology of this is the organism infects the vascular endothelium with subsequent vascular injury in the organs and leading moving from the skin to the various organs like kidneys, uh, meninges, and brain also. Clinical features can be if there is fever, there is rash, there is arthralgia, there is myalgias, and very severe myalgia. Specifically, the calf muscles are very tender. When you just touch the calf muscle, the patient winces with the pain. Then altered sensorium can be there when you can have meningoencephalitis. There can be icterus that can be there, and stupor can be there in later on stages. Lab diagnosis is wheel Felix test, and also you can have immunological test to diagnose the scrub typhus. Treatment part, very easy to do, but you have to suspect it. Doxycycline is the best drug, most potent, and even it is the diagnostic test. When you start doxycycline, patient should be afebrile within 48 hours. So that indicates you are talking about scrub typhus. That is even it's a diagnostic process you can have using doxycycline. This is one of the diagnostic modality you can have in this scrub typhus. Otherwise, if your patient is pregnant, you can use azithromycin, or patient is not tolerating doxycycline, you can use again azithromycin. Even rifampicin is also good for these type of patients. Chloramphenicol can be used in this type of patients also. So scrub typhus is not rare to us; it is common. But importantly, how to suspect scrub typhus? I think I have missed one thing, that is eschar. I will talk about this. So what is scrub typhus? Basically, it is a rickettsial origin infection. It is eschar, doxy, and fever. But importantly, awareness is very important. If you miss scrub typhus, there can be mortality. 50% of that, these patients can have mortality if you miss that. Very common in Rajasthan also, and also in Andhra Pradesh and Rajasthan, they are having high prevalence of scrub typhus. And rats and rodents are basically natural hosts, whereas humans are incidental, or you can talk they are accidental hosts. So most of the time it is rats and rodents which are there. Usually typhus and spotted fever, they are the two type of rickettsial illness. So typhus can be Indian typhus or a scrub typhus, whereas spotted fever, you all know it can be it is Rocky Mountain fever, or it is a Indian pox. Why we are having scrub typhus more these days? Because of deforestation. We have encroached about that area of these forest area has been decreasing, and it's a that's why these type of zoonoses are occurring more commonly. So awareness is very important. Then we have to look at the lab diagnosis, and then if the presentation is delayed, or late presentation, or delayed diagnosis, or delayed treatment, it can lead to a lot of mortality. If you want to suspect scrub typhus, fever with encephalitis with thrombocytopenia, suspect scrub typhus. This is very important. What is the meaning of scrub typhus? And scrub is basically, it is a vegetation which is grown in the wild vegetation, and typhus means a fever with a stupor, and everything has meaning. It's a Japanese term, that is sutsugamuchi. Sutsu means small and dangerous, and muchi means it's insect or mite. It is disseminated vasculitis, endothelitis, vasculitis, and there is perivascular leakage, which is very important in scrub typhus. Larval mite, the chigger, larval mite, it feed on the host. This is the only stage which feeds on the host. Otherwise, most of them are feeding on the rodents and other vegetations. A scar, where the bite of this mite or the larval bite is there, there is a scar formation. A scar is different than the scar. A scar is basically, it is a full thickness ulcer, and it is dried up ulcer. So, and there is, the ulcer has got a slough and it has got margins. Whereas a scar, it is a dried up slough which is there, necrotic dark colored slough will be there with undermined edges, and there is surrounding, there will be erythema. We were able to detect 2 patients with a scar, and a scar is present. Where to look at a scar? You have to look at the sleeves or creases of your clothes. It is inside the covered area, under armpits or behind the neck or in the groin area. You will find a lesion that can be a scar. So if you find a scar, and patient is having fever, no need to wait for the test, start doxycycline, because as this scar can will be there within 3 to 5 days of the infection. But sometime you may miss the scar, specifically in dark colored patients, dark colored people, like Indian patients. Indian are dark colored, so we can miss a scar. So we say that around 50% of them may not be having a scar. So initially, scar may not be ulcerative. A scar can be vesicular in the early phase, but later on it can be, you can have that ulcerative phase or clear-cut formation of dry necrotic scar or a full thickness ulcer that can be there. So the commonest site, remember, commonest site are axilla and back and groin area. These are the covered areas which are importantly picked up by these larval mites. Second thing which happens is a maculopapular rash. Now, rash in typhus is different than the rash of dengue fever. I will be talking about dengue fever. In scrub typhus, the rash is maculopapular. It is first comes at the trunk. So, how I remember about the trunk? Typhus means trunk. So, trunk involvement is the first. Then it is spreading to the limbs. Face is most of the time it is spared. So this is important. Then you can have lymphadenopathy, cervical lymphadenopathy, hepatosplenomegaly. You can have suffused conjunctiva or conjunctival swelling will be there and congestion will be there, but lesser than, not much, lesser than leptospirosis, lesser than Zika infection. So less conjunctival, but suffusion will be there. Headache will be very common. Headache will be there. Patient will be drowsy, apathic, and myalgia. And shin, specifically, you touch the shin of the patient, he will be having severe pain. Then systemic signs comes after, say, 1 week. So nearly around 1 week after, nearly in the second week, you find systemic signs are coming up. Here you will have all type of systemic sign. You can have myocarditis, you can have meningoencephalitis, or acute kidney injury or ARDS. Acute pancreatitis has been reported with scrub typhus, and GI bleed has been reported, and our patient had GI bleed with ARDS with scrub typhus. Respiratory failure is type 1 respiratory failure. We do the blood gas analysis, you will have hypoxia and you will have washout CO2. And this is type 1 respiratory failure. Lung involvement can be ARDS type, or there can be diffuse lung involvement, diffuse lung infiltrates will be there. Pulmonary hemorrhage can be there, or you can have pulmonary edema type of thing. Which are the patient of scrub typhus which can have lung involvement? This is again very important. You must pick up these type of patient which can go into lung involvement. These are the patient who delayed the treatment, delayed diagnosis, high WBC count, this is very important. And then low hematocrit and high bilirubin. These are the patients which will go into ARDS, so you have to be very cautious. You do HRCT, there will be ground glass opacity, there can be reticulonodular pattern, and that indicates that lungs are clearly involved. So malignant encephalitis with rash, with scar, with thrombocytopenia and fever, this you have to suspect the scrub typhus. Why I am talking about meningoencephalitis? Because I missed this. I missed the diagnosis of scrub typhus. Whenever a patient comes to you with meningoencephalitis, we diagnose it and we look at the CSF. What we rule out bacterial meningitis, we rule out tuberculosis, we rule out viral. But most common Indian studies have shown that most commonly in 36 to 40% cases, you are missing scrub typhus as a cause of meningoencephalitis. How to diagnose? Weil-Felix reaction, Weil-Felix test we are not doing now, but Weil-Felix is the cheapest test you can do, and but it has got low sensitivity, very low sensitivity, but yes, specificity is high. Actually, it is a antigen cross reaction between Proteus, and you find the antibodies against this antigen, and you detect Weil-Felix titer. If it is more than 1:320, higher than that, you diagnose positive, it is positive. Or if you are having baseline 1:50 and it is 4 times higher, then you diagnose it as scrub typhus. Otherwise, ELISA test for IgM and antibodies is the most sensitive, but best is done best when ELISA is done when you have after the end of the first week. So before first week, you have to empirically treat this patient with doxycycline. And doxycycline, if you are giving oral therapy with doxycycline, I had one problem with my doxycycline. Very easy to give, very cheap medication, but it can lead to severe or esophagitis. So give doxycycline tablet always sitting posture or standing posture with lot of water. So remember to give doxycycline like this. So fever, positive fever with more than 5 days duration, look for strep typhus in these type of scenarios. Now coming to another uh, more common infection, that is dengue. So causative organism is dengue is flavivirus, it's RNA virus. Vector is Aedes mosquito. We have all seen Aedes mosquito. It is a tiger mosquito, or it has got white spots on the trunk and also on the limbs, on the legs also. Pathogenesis, it can be cross reactivity. That means you have got previous dengue, you recovered, you develop immunity that against that strain. So it is a lifetime immunity, but for short time you can have crossed immunity. So most commonly it is secondary dengue which we are having now. Amplified cascade of cytokines and complement activation. It can be antigen antibody reaction where complement fixation happens, and there can be antigen antibody reaction. Immune mediated injury can be there, and then endothelial dysfunction. Clinical features are incubation period of 4 to 10 days. You can have dengue fever, you can have dengue hemorrhagic fever, or dengue shock syndrome. Dengue hemorrhagic and dengue shock syndrome are basically when you admit these type of patients. Headache, retrobulbar pain, this is very important. Retrobulbar pain, आंखें फटने को हो जाती हैं, coming out of eyes, ऐसे लगता है आंखें बाहर निकलेंगी. Headache, retrobulbar pain, myalgia, arthralgia, but this arthralgia is lesser than chikungunya. And rash in dengue fever is very fine rash, just as a coating is being done, including face and whole of the body. And most of the time it is a pruritic rash which happens in these type of patients. And there can be a waxing and waning rash also. The rash can come and rash can go, and even terminal phase of illness, or when patient is recovering, again you can have rash with dengue type of dengue fever. So rash has to be differentiated from scrub typhus also, and similarly from leptospirosis. You can have dengue hemorrhagic fever when you have thrombocytopenia. Skin, mucosal or GI bleed can be there. And then you can have dengue shock syndrome when you can have weak pulse, cold clammy extremities, tachycardia, cold clammy extremities, sweating, and decreased pulse pressure. Decreased pulse pressure or mean arterial pressure. That means decreased difference between systolic and diastolic pressure. This is the most ominous sign. Most ominous sign that if the decrease is less, if it is less than 20 millimeter of mercury, that means your patient is landing up with lot of problems. Patient has got lot of plasma leakage, and you have to admit this patient, treat in a proper way. This is very important. Otherwise, patient can go into extended dengue syndrome. That can be encephalitis, there can be myocarditis, or there can be resistant shock, hepatitis, renal failure, ARDS, and hemophagocytosis that can be there. How to diagnose dengue? Rapid CAR test. We go by the NS1 antigen, and that is positive at the day 1 of the fever. And then you can have IgM, IgG serology after day 4 or 5th of the fever. You can have this test positive. So NS1 positivity can be there in the first 1 day. Just on the first day of the fever, you can have non-structural protein that can be positive. How to treat? Isotonic fluid, that is important, and blood transfusion as per requirement. Now, just elaborating the whole story of dengue fever. Dengue fever, you have various sera, or there can be various serotypes can be there from 1 to 4, but now we have got 5 also, that is there not in India, but Malaysia have got 5th dengue also. So 1:4, and these are various sera, but how they are different, all seras can cause severe and fatal disease. Remember, it is not one cannot cause, it is only 2 or 4 which are dangerous. It can be all sera. They can all cause severe and fatal disease. There are a lot of genetic variation in these serotype, and there can be more virulent type 1, more virulent type 2 that can be there, or higher epidemic potentials can be there in various type of these genetic variations. Now, importantly, this Aedes mosquito, Aedes mosquito is very different type of mosquito because it bites in the daytime, and the dawn and dusk phenomena is there. Early morning and or the evening hours, it bites its own. Most of the bites has been happening in this time. Then the flight distance is around 100 meter. So that means it bites repeatedly and multiple household members are involved. And this is happening in our routine OPD. You can see mother, father, brother, kids, they are all having this fever. And then importantly, the height or the flight height of this mosquito is just 4 feet. That means the areas to be covered, or areas where it bites maximally, are your hands and the feet. These are the uncovered areas around ankle and the feet and the hands. These are the uncovered areas which are being targeted by, which are being the main target by this mosquito. So we have to cover these areas if we want to prevent the bite of dengue fever, this mosquito. So there are two type of injuries which happens in dengue fever. One is direct cellular injury. The direct injury of the by the dengue virus can be up to endothelial cell damage that can be there. There can be macrophage activation, or there can be platelet destruction. So all these three can be there in you have direct injury by the this virus. Then indirect injury can be there. I have told you that there can be antigen antibody reaction, complement fixation that can be there, and T cell activation can be there. You can have cytokine storm. So most commonly which we are having when patient lands up in the ICU or in emergency with you and with a complicated dengue hemorrhagic fever or dengue shock syndrome, it is secondary dengue which is leading to antigen antibody and complement fixation reaction, that is immune complex damage to the various organs. Clinically, how to suspect? Tourniquet test is important test. You do tourniquet test, and I think everybody must be knowing now that you calculate you check the systolic blood pressure and diastolic blood pressure. You add it. Suppose it is 110 plus 80. 110 by 80 is the systolic and diastolic. You add this and make a half of this. So take half of this blood pressure and inflate the cuff up to half of this for 2 to 5 minutes, and then check for the petechial hemorrhages, and that this petechiae will be there and in the area of 1 square meter, 1 square inch, and you see around 10 to 20 petechiae. If they are there, then the tourniquet test is positive. This indicates your capillary fragility. Myself, clinically, how I check for the tourniquet test, I don't find this much amount of time in my routine OPD. So if you press the abdomen or the trunk area or arm area or the forearm of the patient with your hand, just with your hand, and with a sufficient amount of pressure, and this pressure is sufficient, means you blench your you blench your nail beds, that, and you maintain it for say 2 or 3 seconds, and then you just remove it. You can find there as fingers are being there will be image, there will be just you can find your fingers impressions clearly demarcating that you are having capillary fragility. So it's a very important test you can do in routine practice. So you can have, so in dengue fever, you must look at the warning sign. What are the important warning signs that you patient requiring emergency treatment, patient requiring fluid therapy, patient requiring admission? Abdominal tenderness, right hypochondrial tenderness is very important. Vomiting, incessant vomiting, or bleeding from any site, or you can find that there is a 2-finger enlargement of liver, or hematocrit. The most important thing in dengue fever is not platelet, it is hematocrit which is most important. Normal hematocrit is between 44 to 54, or roughly I take around 40 to 50. So don't have more mathematics. 40 to 50 is the normal hematocrit. or you can take it PCV. So if your hematocrit is rising by more than 20%, that means there is plasma leakage that is happening. You have to give the fluid. And by giving fluid, the sufficient amount of fluid should be given. It should not be overloaded. So adequate amount of fluid has to be given, and that should be isotonic fluid infusion. And isotonic fluid infusion means 0.9% normal saline or ringer lactate or 5% dextrose normal saline, but never give hypotonic 5% dextrose. So this is normal fluid which we give. So, and how much amount of fluid has to be given? It has to be given only to maintain adequate hydration and adequate amount of urine output, not to overload, not to overload your patient. And the clinical sign that hematocrit has to be done every day or CBC has to be done every day. So mark one day and the second day and third day. And if there is decreasing by 10% hematocrit, that means you are okay, you are in line with the adequate amount of hydration. Suppose your hematocrit going down very rapidly, less more than 20% decrease in hematocrit. That indicates there is some amount of internal bleeding is happening. So you have to transfuse this patient with either blood has to be given in this patient. Otherwise, if you delay it, patient can go into a dengue shock syndrome, and that can be a very tedious thing, or very you can have a lot of issues in managing these type of patients. Now, what not to do in dengue fever? What not to do in dengue fever? This is again very important. Uh, uh, I have told you admission of dengue fever. So if you take every dengue fever admit in your patient, it will lead to lot of overcrowding. So don't admit fever, simple dengue fever. Don't admit with a fever in these type of patients, because you require beds for those patients who are having dengue hemorrhagic fever, dengue hemorrhagic syndrome, or dengue shock syndrome. So you have to make your bed available for these type of patients. Then NSAIDs not to be given. Any NSAID not to be given. Intramuscular injection. Recently, we gave one intramuscular injection, and we have got a big hematoma on the buttock of the lady of that dengue fever. So inadvertently, that was given in the emergency department. So intramuscular injections not to be given in this dengue fever. Then corticosteroids are not to be used. Not to be used. Antibiotics, no use, friends. There is no use of antibiotics in dengue fever. Then every day you have to do CBC and concentrate on hematocrit. Don't think about platelets. Total platelet count means nothing in these patients. You require platelet transfusion only when your total platelet count is 10,000, less than that, and patient is hemodynamically unstable. So patient recovering, adequate amount of hydration given, wait for the patient to improve itself. No need of giving prophylactic platelet transfusion. Don't give any hypotonic fluid, remember. And also just give adequate amount of fluid. Don't push fluid in the patient unnecessarily, because what happens in the later third stage, that there are three stages. One is febrile stage, another stage is thrombocytopenic stage, and there can be plasma leakage in that stage. And the third stage is reabsorption stage, where the fluid which has been there in the third compartment get reabsorbed. And if you overhydrate this patient, your JVP is full, your chest is congested, basal cramps are there. This means you are overhydrated the patient. This patient will land up in pulmonary edema. Definitely will land up in pulmonary edema, because there will be reabsorption of that fluid into circulation that will lead to a lot of problem in these type of patients. So watch your hematocrit. This is very important in dengue fever. Next is malaria. Again, very, very common. And we think malaria is very easy to treat. It is chloroquine and primaquine and the epidemic is gone. No. Malaria is a havoc. This is the most common. This is the king of the parasitic disease, because if you manage properly and treat it, the patient will be okay. Patient will go home within 3 days. But if you delay the treatment or mismanage or misdiagnose, then it can lead to high rates of mortality. Causative organism, Plasmodium protozoas, Falciparum, Vivax, Ovale, and Malaria. Vector is Anopheles mosquito. Pathogenesis, the problem issues related to malaria is mechanical microcirculatory obstruction due to Role formation of RBCs, and there is intravascular hemolysis. Clinical features, paroxysms of fever, shaking, chills, sweats, and that is occurring every 42 to 48 to 72 hours when you have RBC lysis and cytons are coming out from the RBCs, infected RBCs, then you have paroxysm of fever. Diagnosis, by doing microscopy, you go by the thick and thin film, and also by rapid diagnostic test, and that you look for the PLDH test, that is optimal test, or also for histidine rich protein 2 for the falciparum. So this is rapid diagnostic test. So malaria is ruled out only if two negative rapid diagnostic test. Most of us, we have just forgot our thick and thin film, but they are most important. Never diagnose malaria only on the basis of rapid diagnostic test. Yes, they are good for screening purpose. They will give you initial diagnosis, but you have to look at thick and thin film. By thick film, you will get the infection diagnosis and also about the parasite count. And by thin film, you will see the type of the parasite which is infecting. So whether it is falciparum or whether it is a vivax, you diagnose it from the thin film. Treatment is, the drug of choice is artemisinin derivatives or artesunate. So the malaria is very important. There are 5 species of malaria. Remember, vivax, malaria, ovale, falciparum, and also semi-ovale, that is also known for causing it. Malaria and dengue, and also scrub typhus, even leptospirosis, all these tropical fever are notifiable diseases. Remember, once you get falciparum malaria, once you get dengue hemorrhagic fever or dengue shock syndrome, you have to notify to the authorities regarding the occurrence of this disease. Why we are having more malaria, and upcoming malaria will be there because of global warming. So if average air temperature has increased by 0.45 degrees centigrade, and over last century it has increased and going to be 1.8 to 4.5 degrees centigrade rise by 21st century. So higher the temperature, more multiplication of the mosquito, more reproduction of the mosquito, longer lifespan of the mosquito, and more infectivity of the mosquito will be there. So be prepared. You are going to have more and more malaria. Don't think artesunate are going to remove the malaria from the globe. No, never. It can never happen. We must know about these species: vivax, ovale, malaria, and falciparum. Why it is important? Vivax and ovale, they have got very important liver phase, and liver phase means they can have hypnozoites. Hypnozoite means they can have dormant stage. That means there can be relapses after the full treatment. There can be residual infection that can be there in the liver, which can again come up. So you have to give radical treatment. So with vivax infection, primaquine treatment has to be given for 2 weeks. This is very important. Write down somewhere. You have to give primaquine, but before giving primaquine, check G6PD deficiency. So in those patients not to give primaquine, even mild cases of G6PD deficiency, still you can give primaquine. But severe cases of G6PD deficiency, not to give primaquine, but otherwise for P-Vivax, you have to give primaquine for 2 weeks. Then for regarding how much type of RBCs they infect, Vivax and ovale, they infect young RBC, whereas falciparum, which is much more commoner, very dangerous, 40 to 60% cases are falciparum malaria. If you have got undiagnosed malaria, treat it as falciparum malaria. Remember, treat it as falciparum malaria. 40 to 60% cases are falciparum malaria. Why we are worried about falciparum malaria? Because it has shown chloroquine resistance. All kind of RBCs are involved, young or old RBCs. So very heavy paracytemia can be there. And then uh, you have to give primaquine also with falciparum, that is only single dose. So that is important. There are two things which are again which has given me a shock somewhere. Sometime I will let you know how that changed my perception toward malaria. I read somewhere in Harrison that sickle cell anemia, they are resistant to malaria. So these are the patients which will not have malaria. Also, G6PD deficiency, they will be also resistant to malaria. But friends, G6PD deficiency patients can have malaria also, but if it is mild. But in this patient, if you have to give primaquine, you have to check G6PD deficiency. So don't think malaria is there, G6PD deficiency will not be there. So always you have to check G6PD deficiency once you want to give primaquine. So remember, malaria can mimic anything, almost anything, and everything what you know about medicine. It can present as a coma, it can present as a hepatic failure. We have seen patient presenting as cerebral malaria, we have seen patient presenting as a shock syndrome, we have seen patient presenting as black water fever, acute kidney injury. We have seen patient who were present with malaria and pneumonia. We were foolish at that time. We thought that this is streptococcal pneumonia or some other bacterial infection, but it was malaria which was causing this pneumonia. So you can have all atypical presentation with malaria also. There can be atypical fever. Don't think it will come as a spike. It can be benign. It can be tertian fever or different type of fever that will be there. No, it can be atypical fever, simple headache, joint pains, vertigo can be there, acute psychosis can be there, convulsions can be there, coma can be there, even anasarca can be there, or even acute abdomen, diarrhea, organomegaly, and severe anemia, non-responding anemia with hepatosplenomegaly. You have chronic malaria as a diagnosis. Specifically, when you talk about falciparum malaria, specifically when you talk about extreme of ages, pregnancy, and end stage organ failure patients, and immunocompromised patient and diabetic patient, you can have various different presentation of malaria also. When should we hospitalize malaria patients? When fever is there more than 48 hours after initiation of treatment. Secondly, when you have patient having headache, if it is worsening headache, you have to admit this patient. Then if vomiting is increasing, incessant vomiting, and patient is not taking orally, sick looking patient, patient is prostrated, dehydrated, and and also high risk patient like diabetic patient, elderly patient, extreme of ages patient, organ dysfunction patient, you have to admit these patients. And then dark colored urine, that is black water fever, that is there, so you have to admit this patient. So remember, thick and thin films are very important. Even when your lab technician comes with a car test that that malarial antigen test is positive, why should I go with the thick and thin film? Not, you always insist that thick film is required for diagnosis of the parasite. Plus, you want parasite count. Remember, you want parasite count in your patient. Then thin film is typing of the parasite. Now, Dr. Sanjay must be remembering how we used to look at the thin film. We have to look at the signet ring appearance. Vivax was having single signet ring in the RBC, whereas this falciparum used to have 2, 3, 4, 5 signet rings. Multiple rings were there in the RBC. So we have that microbiology slide of that was very important for us. Now look at the rapid diagnostic test, that rapid test which patient which you always ask about, that strip of rapid diagnostic test which that is done in your lab. Because if there is only single line, that means this RTD is negative. If there is two lines are there, that means you have got Vivax. But if you have got three lines are there, that means you have got falciparum malaria. So that's how. But another important thing I will let you know, that with experience to treat malaria, sometimes there are certain things which happens in your ICUs. Number one, you don't inject chloroquine. Don't give IV chloroquine when your patient is having rigor, chills, fever, dehydrated, sick looking patient. Stabilize your patient first. because chloroquine single injection can lead to severe cardiac arrhythmias. Ventricular arrhythmias have been reported with IV injection of chloroquine in these type of patients. Giving primaquine, rule out G6PD deficiency. Don't forget primaquine specifically in P. falciparum. Don't think that there is no liver phase, so don't give primaquine. Not to. Primaquine is the one drug which is effective in human and also in the mosquito. Don't give monotherapy of artemisinin when you have got complicated uh, malaria. Either combine it with lumefantrine or combine it uh, 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 with doxycycline or azithromycin, or best is with clindamycin. If you have got simple PYVX, don't give artemisinin. Chloroquine is the drug of choice. There is no empirical single shot therapy of malaria. Don't give एक टीका लगा देता हूं कोई बात नहीं. Don't give single shot therapy. Then don't give parental monotherapy with artemisinin in OPD. You have to admit these patients because these patients can have issues. You have to give loading dose 2.4 milligram per kg body weight first dose. Then you have to give it 12 after 12 hours, then after 24 hours, then every day till patient is afebrile and patient is out of problems. Then most probably it has to be given up to 7 days. My own practically, some books says 3 days, some say 5 days, but practically I go by the 7 days. Get parasite typing before treatment. Thick and thin films are very important. So now coming to the enteric fever. The causative organism is Salmonella typhi. Transmission is focally contaminated food and water. Pathogenesis, bacteria spread throughout the reticoendothelial system. Peyer's patches are most importantly involved because they have got the maximum lymphatic tissue at the level of intestine, so that they are most importantly involved. Clinical features has got incubation period of 1 to 14 days. There is fever, headache, relative bradycardia. This is important. You can have relative bradycardia in Lyme's disease, in leptospirosis. So there is relative bradycardia, abdominal pain, diarrhea, constipation, hepatomegaly, encephalopathy. But encephalopathy has become less common nowadays because of easy availability of diagnostic tests and early pickup of typhoid fever. Intestinal bleeding has been there. Perforation we have reported. Perforation also. Multi-organ dysfunction has been also there with typhoid fever. Diagnosis, very important, typhoid dot test, but typhoid dot test is positive after 5 days of infection. No need to do typhoid dot on the day 1 of the fever. You will not find any typhoid dot positive. Only thing that will be helping you is blood culture in the early phase of typhoid fever. After 5 days, typhoid dot will be positive. Vidal test will be positive only after 2 weeks of 10 days to 2 weeks of the fever, and you have to report the rising titer. We don't go by the Vidal test because of lot of anamnestic reactions. Blood culture is the best or the gold standard for diagnosis of typhoid fever. And recently we are compiling up a data of around 35 patients in recent 2 to 3 months where we have negative typhoid dot but positive blood culture, and typhoid dot has been done at a proper time. Negative typhoid dot and blood culture positive for Salmonella typhi, and these patients are sensitive to most of the drugs, even quinolones, and also for third generation cephalosporin, ceftriaxone. Bone marrow cultures rarely done, but that can also help you in certain cases. First line treatment is ceftriaxone. Importantly, it is ceftriaxone. Mostly we add azithromycin for 5 days, 500 mg BD, or ciprofloxacin. That dose has to be increased. Use 750 mg of ciprofloxacin if patient can easily tolerate. BD dose of ciprofloxacin and ceftriaxone. Now coming to yes, Japanese encephalitis. We had one patient with Japanese encephalitis recently. Causative organism, Japanese encephalitis virus. Vector is Culex mosquito. Pathogen is virus reaches the CNS through leukocytes. Clinical features with the incubation period of 6 to 8 days, with the range of 4 to 40, 15 days. Prodromal period is has fever, headache, vomiting, and myalgia, and altered sensorium of in these patients. Seizures are there. So these are the patients which will have more of encephalitis and least amount of meningitis. Diagnosis is IgM capture ELISA serum and sportive treatment, airway management, seizure control, and management of raised intracranial tension may be requiring short course of mannitol or Dexona that can be given in these patients. But no need of antiviral therapy. No need of antiviral therapy. Yes, you have to do MRI scanning of the patient and see whether it is fitting into herpes type of viruses or not. If it is, there is no specifically areas which are involved in herpes virus and encephalitis. If that is not there, no need to give acyclovir in these patients, and you can manage these patients in a sportive way. And there are most of the time the best the reporting of MRI will be showing there will be hemorrhagic infarcts. There will be hemorrhagic areas which are characteristic of Japanese encephalitis in MRI scanning. So if you see these patients of fever, there are overlapping signs and symptoms. So many times, till you have got concrete diagnosis, you have to treat these patients empirically. So syndromic approach to tropical infection is important. Choose early empiric therapy, and this empiric therapy can include anti-malarials, which most of the time I don't do. I keep on looking at look whether ruling out malaria right at the beginning by doing repeated uh, 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 rapid testing, thick and thin film. Also, I see that it should be clear. We should pick up malaria within first 24 hours of the patient. So we should not delay the treatment of antimalarial. Should not use it empirically. But antibiotics like third generation cephalosporin, like ceftriaxone, then doxycycline, because doxycycline is a multipotent drug. It can give you coverage for many infections, even rickettsial infection like tropical, most of the tropical infections. Even it works in typhoid, paratyphoid fever, cholera, bacillary dysentery, bacterial meningitis also. IV doxycycline works here, and scrub typhus, leptospirosis. The drug of choice is for scrub typhus is doxycycline basically. For and then if you combine it with third generation cephalosporin, I think you are covering most of these tropical fever. Even leptospirosis has been covered by using third generation cephalosporin. Until you get that proper diagnosis, then you can down escalate and give the appropriate therapy, appropriate treatment of these patients. Thank you for the thank you for the patients listening. Thank you.
Thank you, Dr. Sandeep. Really exhaustive discussion on tropical fever, the various syndromes, and how to manage them. Sir, lots of questions, if you can take a few. I think this question from Dr. Vishnu Mulchandani, we've already taken. What are the red flags that we need to consider if we have to refer or admit a serious patient? But anything specific you would like to add to whatever you've already shared?
See, basically hemodynamic, you have to look at the vital signs of the patient and see how, and basic risk factor of the patient. If patient is already high risk for deterioration or multi-organ involvement or extreme of ages, or patient is already on polypharmacy, or patient is having some chronic steroid therapy or immunosuppressive therapy already there. So these are the patient which has to be referred right at the beginning.
And another question, this question comes from Dr. Gangadhar Rath from Karnataka. Sir says these days we are seeing a lot of dengue fever patients and they have thrombocytopenia. Is there any single threshold for transfusion, platelet count threshold?
See, my take is 10,000. I go by 10,000. 10 is the cutoff, because below that, it might improve. Next time you check, it may be 12,000, or it may be 15, or it may be 20, but it can go down to 5,000. So there it can be, you can have internal bleeding. So that you might miss. So best is by 10,000, and if there is slightest hemodynamic compromise of the patient, you give single donor apheretic plasma therapy.
Thanks. From Dr. Raj Kishore Maheshwari, we have a question, a very pointed question. Tropical fever, undiagnosed tropical fever. Would it make sense to start a single antibiotic empirically or to give two antibiotics together?
See, best is to give ceftriaxone and doxycycline combined. If patient is not tolerating doxycycline, then give azithromycin. So give combination, because ceftriaxone will not be covering many, because scrub typhus you require doxycycline. So it has to be given empirically. You have to give multiple therapy.
एंड डॉक्टर मोहम्मद अंसार एक सवाल पूछते हैं, ज़्यादातर फीवर बहुत ही हाई आ रहा है, मगर जब हम टेस्ट करवाते हैं 5 दिन के बाद तो टेस्ट में कुछ भी पॉजिटिव नहीं आता, कभी कभी मलेरिया पॉजिटिव आ जाता है. सो हिज क्वेश्चन इज आइडियली हाउ ऑन व्हाट डे ऑफ द फीवर शुड आई check for malaria to get the maximum yield?
See, if you want to get the thick and thin film, it has to be done right at the beginning on the first day of the fever. And if you want to get the the malaria antigen test positive, that also can be done right at the first day of the fever. So no need to have 2 days, 3 days gap. Now, when to look for the PBF picture, whether at the time of high grade fever with rigors or not. So this is a many times we debated at the bedside in our during our PG rounds. So there are two type of thing. If you have fever, at that time there is lysis is happening. So RBC lysis is happening. So that is the best time to pick the 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 make a PBF picture. But at that time, physiologically there is vasoconstriction that is happening. So best time is just after fever. That will be the best time to go make a PBF picture. Just after fever subsiding, you check the that the PBF picture. That will be more. That yield will be the maximum at that time.
Thanks. Dr. Suri, you had mentioned this threshold of platelets for platelet transfusion, 10,000. Of course, clinical factors will be there. Supposing somebody already has bleeding tendency, let us say there are ecchymotic patches at 20,000 platelet count.
Yes.
It doesn't mean you will postpone. Don't
Yes,
look at the number
definitely.
only. Look at the patient.
Yes, definitely.
But Dr.
Definitely. If there
Mulchandani
is
says,
any bleeding somewhere, if it gum bleeding is there, or sometime menstrual bleeding, that is increased menstrual bleeding is there, or there is bigger patches which are coming up, then you have to give even at the 20,000 platelet.
Dr. Mulchandani asks, how do I decide whether to give a whole blood transfusion or a plasma transfusion or just platelet concentrate?
See, whole blood transfusion is recommended when you have got falling hematocrit. If it is falling hematocrit of 20% or more than that, then whole blood transfusion has to be given. For specifically for taking care of thrombocytopenia, then that 20,000 or ecchymotic patches or bleeding or 10,000 with hemodynamic compromise, then you have to give single donor apheretic platelet therapy donation.
And he continues with the question, if I give platelets today, let us say I give 1 unit now or maybe 2 units now, after how many hours do I check the platelet count again?
24 hours.
What is the 24 hours? What is the average life of these platelets, and when do I decide whether I have to repeat the transfusion?
See, you have to recheck the platelet count after CBC. Basically, we go with the CBC. We are not using the term platelet count. CBC we do after 24 hours, and we see how much improvement has been there. Most of the time, it has crossed that limit, and we are able to add around 5,000 or 10,000 platelets. They are being added. So, and then after that, if it is again required and further fall in platelet is coming, then very rarely you will be requiring another platelet transfusion. Very rarely. Total lifespan of platelet is roughly around 5 days.
Sir, sincere thank you from Mr. Sunny Grover from Haryana, and also Dr. Hemangini Thakkar for the information you have shared. Dr. Manoj Yadav thanks you as well, and from his side, a specific thanks to Kerala team FDC for their wonderful planning. So 3 cheers for team Kerala of FDC as well. Dr. Shazana Haider Ali has a question. Sir, very often we see acute undifferentiated fever. Malaria negative, dengue NS1 negative, dengue IgG, IgM negative. The only thing we are able to say is thrombocytopenia. So, can I fit this as dengue fever, or do I give it another label?
So you can fit as a dengue fever. You can give sportive therapy in this patient. Watch this patient. Look at the CBC, or the WBC count, which is lower. That is the earliest to rise. If it is rising, it is normalizing. The platelet count will come up. Look at the hematocrit, hemodynamic profile of the patient. I think these patients can be easily managed if you give all the sportive therapy. So even if you are not able to make a proper diagnosis, still you can manage these patients without doing any hanky-panky.
Thank you from Dr. Sanjay Marathe as well. And Nitin Narula Sahab asks, for chronic fatigue syndrome or fatigue after fever, post-febrile fever, what is the best vitamin to give?
This Dr. Sanjay will be more, more appropriate to answer.
Nitin, I
It's a
think
vital.
good food would be the right answer. High protein diet. If
Yes,
there is one thing that will improve immunity, that is high protein diet. So
yes,
tell your patients not to starve. They should
yeah,
eat or drink regularly every 3 hours. Anything is fine. I mean, if they don't have diabetes, Coca-Cola is also fine. Ruh Afza is fine. Anything
yes,
should go in. But make sure protein intake is adequate.
yes.
Eggs, milk, these would be suggested. Another question from Dr. Shazana Haider Ali. Sir, can we give half-strength dextrose, especially to younger patients, half-strength dextrose saline?
See, half cent dextrose, that means 0.45% dextrose. So that will be hypotonic. And I think that should not be given. It is 0.9% normal saline or 5% dextrose normal saline. So that is isotonic. And then, or ringer lactate. That is the important thing. Don't give any hypotonic. And sometimes there is a confusion whether we should give crystalloid or colloid. So, and starch is there or dextran is there. So, critical care society, they have shown that they are both are equal to replenish the your plasma volume, to replenish the, to make a proper cardiac output. Both are equal to take care of the shock. But first preferred is crystalloid. First preferred crystalloid. Now, when to give colloids? When you find that you have got resistant to crystalloid, you have given enough amount of crystalloid. Now again, if you give more crystalloid, you will have more pulmonary edema. So to prevent pulmonary edema, that is the time when you should give colloid. So resistant cardiogenic or resistant shock with adequate cardiac output, that means
Hmm.
you are you want that colloid should be given in this type, these patients.
We take Dr. Biswajit Haldar's point well, and please do a session of latest diabetes medicines. After sir, after 2 more weeks, we'll come back to diabetes and diabetes essentials. We are currently on this series of topical fevers, and like Mr. Ankur said and Mr. Basu tells us, actually across India there is this epidemic of fever. So we thought that we should focus on fever for this 2 months.
Yes.
From Ashirwa tutorial, a question. Sir, if malarial test is negative, but the patient has symptoms, clinically I suspect malaria, there is no other positive cause. Can I give anti-malarial? Am I justified in
Yes,
doing
you
that?
can. Yes, you can give chloroquine. Chloroquine you can give. There is no issue.
And I think the WHO also recommends that even if
Yeah,
MP is negative
yeah,
and you are working in a malaria endemic area, there is no excuse not to give chloroquine.
yes.
Why only paracetamol is considered safe in fevers?
And that is also not crossing the 5 gram per day. So
Yeah,
that dose
not
has
very
to be
safe.
less than 4 gram. So it is basically, it is not hampering any platelet function, and these chances of having GI bleed and related issue, prostaglandin pathways is not much targeted by uh, uh, the paracetamol, and that's why we are much more worried about the uh, platelet function, which is disturbed in dengue fever. So we think, we recommend that only paracetamol has to be given. You can repeat the dose, but less than 4 gram per day, that has to be taken. And that is the ceiling for the paracetamol also.
Thank you from Dr. Suresh Shukla as well. Dr. Biswajit asked about nutraceuticals. So these are helpful actually. Now, see, the best immunity builder is good nutrition, but sometimes our patients are not able to take enough because the appetite is low. They don't like the sight of food, they don't like the taste of food. So that is when nutraceuticals help, whatever kind of nutraceuticals there are. Usually, when we speak of hunger, we speak of protein energy malnutrition. But there is something known as hidden hunger as well. Hidden hunger means micronutrient deficiency. So you might have deficiency of vitamins, deficiency of minerals, deficiency of electrolytes. And all these can be covered by adding the appropriate vitamin or the appropriate electrolyte drink. Now, it will depend upon your patient what kind of diet he or she was on earlier. Is the patient on a restricted diet, maybe vegan, vegetarian, then the need for vitamin supplementation goes up. What is the kind of dietary intake right now? What is the cost of fruits and vegetables?
Yes.
Now, if apple costs 200 rupees a kg, you will not tell the patient to eat 4 apples a day.
Yes.
You would be better off giving a nutraceutical preparation. But if, let us say, the fruits are very economical, maybe papaya is costing only 10 rupees a kg, suppose, then you ask them to eat the papaya. Otherwise, the extract would be better.
Yes.
So just look at it from that point of view as well. Sir, it has been great being with you, and we didn't even realize the time, Dr. Sandeep. Thank you so much for all your insight, all the advice that you have shared. Two more questions. One is from Dr. Raveen Thakkar, and he wants to reconfirm dengue with a moderate rise of SGPT, of liver enzymes. What does this tell us, and how do we interpret liver enzymes in dengue fever?
See, transaminitis is very common in dengue fever. It can be in the dengue fever, it can be there in dengue hemorrhagic also. So don't worry about the transaminitis, but keep on a vigil on that because it may deteriorate. These patients can have severe transaminitis. They can have hepatitis also when bilirubin will rising, and also these patients can go into hepatic encephalopathy has been reported. So you have to keep a vigilant proper focus on these patients and look at the AST, ALT on repeat follow-up also in these patients. But not to worry, not to admit these patients unless they fit into the criteria of admission. Don't think fever, dengue, fever, and transaminitis mild or mild thrombocytopenia. Don't try to put them inside in the hospital.
Dr. Mahinder Sharma shares that in the periphery, in many parts of the country, still MP detection on slide test is not being done, the thick film and the thin film.
Yes.
And that is unfortunate, actually.
Yes.
So
yes,
if your pathologist is not doing it, if the laboratory technician is not doing it, you take a lead yourself, begin doing it.
Yeah.
In our residency, we remember there used to be a separate laboratory in the ward, and we had to learn how to do all these slides ourselves.
Yes.
Dr. Sharma also asks about hematocrit. Is there any threshold for hematocrit? Like we keep on speaking of platelet count threshold. Dr. Suneet Verma has been with us earlier on the show, and he says that hematocrit or PCV is more important as a number as compared to platelet. So, sir, your comments on this as
Yes,
the threshold?
absolutely. Hematocrit is a great guidance. How much amount of fluid you have to give, whether your patient requiring blood transfusion, whether your patient is improving or not, irrespective of platelet count. Two things are important. Another indicator that your patient is improving, your WBC count, which is leukopenia, now it gets improved. That also indicates that your patient is improving. So hematocrit and leukopenia, these are the two things which you have to watch. So the cutoff value 44 to 54, or hematocrit in our time, Dr. Sanjay must be remembering, we talk about PCV. So that was packed cell volume. So that was percentage, and it was higher the percentage, more thicker blood will be. That means more plasma leakage will be there. Lesser percentage, more RBC deficiency will be there. That means you require blood transfusion in this patient. There must be some bleeding inside.
I continue to use PCV when I think and when I speak both. Though now hematocrit is used. So if the PCV is high, this is for Dr. Sharma, that means there is hemo concentration. And it is not a nice thing in dengue. It is also not a nice thing if your patient happens to be on exogenous testosterone. It means you are giving too much of testosterone. And the leukopenia is because of bone marrow suppression. So when the WBC count begins to rise, what it means is that the bone marrow has overcome the initial insult and now is coming back to normal. So that is a good sign. One last question, sir. Any role of neutrophil lymphocyte ratio in diagnosis of fevers? This question is from Ashirvad Tutorial.
Yes. this has been we can use this, but I'm not much fond of using this. Specifically, I look at leukopenia, that is more important. Then lymphopenia is also important when you talk about dengue fever. That indicates lymphopenia is also there. But ratio, if it is lower ratio, that indicate lymphocytosis is there, and less neutrophils are there, they indicate something different. It can be more of a HLH type of phenomena that is happening, more bone marrow suppression, more hemophagocytosis, that indicate there is more inflammatory immune response that is happening. So that can one indicator. But don't we should make it very simple, very simple. Look at WBC count, look at neutrophil, seed hematocrit, and platelet. That will be maximum for dengue fever.
Thank you. It's been great being with you, sir. It's 20 minutes past 10 now.
Yes.
And I'm sure Dr. Suri would have had a difficult weekend. His OPD and indoor both are busy. With this, I'd like to thank him once again for his expertise and especially for the humility with which he shares his expertise. And we have Mr. Basu with us. Mr. Basu, your comments, please.
Sir, first of all, a big thank you to Dr. Sandeep Suri, that being a very busy physician, and as you said, he's already having very heavy OPD. He has taken at least 1 hour 15 minutes for such a big deliberation he has given for systemic manifestation of our series, which we are carrying. As I just briefed Dr. Sandeep Suri that we have been carrying this diabetes essential under Dr. Sanjay Kalra for last 3 years, but we take deviations because some of the issues comes up. So when we see that there is a huge number of OPD getting reported in tropical fever cases, we decided that we get the best of the best physicians who are on first-hand experience of treating this. So we decided these topics, and thank you very much that you are one of the batchmates of Dr. Sanjay Kalra and give such a big lecture to us. Thank you very much, sir. See, and I will request Dr. Sanjay Kalra to say from my behalf that in future, if we see such more webinar series, he is most welcome in our episodes, sir. Please, sir.
Thank you.
Thank you
very
and
much.
Jai Hind,
And
everybody.
good night. Jai Hind.
Thank you.